2. If you haven't had a chance, please take a look at the cases in the deck. There's some really nice results, some nice cases. So, all right, you ready?
Yep.
Take it away.
Okay, good morning, everybody.
Good morning.
Good morning. Thank you for coming in the morning, and I'd like to share my experience about my clear aligner case with adult case report. And after 2015, I got iTero 2.9, very bigger one, and I totally switched to the multi-bracket system to clear aligner system Invisalign. So now I'm using over 80 or over 90% with clear aligner treatment. How many of you are using such more than half clear aligner treatment?
Almost.
Nobody?
About 50% of mine.
About 50%.
Yeah.
Probably
Wow.
about 50%.
Okay. During my experience, I feel that this is better to use clear aligners compared to the multi-bracket, and this is only possible with clear aligners case. So I want to discuss this type of cases. So introduction, clear aligner and adult treatment. Clear aligners increasing use in adult cases. Of course, they are concerning about the appearance of during treatment and need for proper assessment of clinical effectiveness and limitations. And thinking about the characteristics of adult patients, jaw growth completed after late teens and wide variations in skeletal patterns and possibility of progressive alveolar bone resorption with aging. So, treatment considerations, special attention needed for tooth movement patterns suitable for aligners and need to prevent unwanted tooth movement and careful management of alveolar bone and periodontal tissues required. So let's think about the efficacy of tooth movement with clear aligners. In Angle papers, clear aligners have difficulty delivering orthodontic torque, and this limitation is likely to persist as long as the appliance remains removable. And vestibulolingual tipping was the most predictable movement, 95%, while rotation of canines, premolars, and lateral incisors were the least predictable, 80%. This number is pretty high between among the papers, and intrusion resulted highly predictable up to 2 millimeter. And aligners seems to be effective in increasing intercanine, interpremolar, and intermolar width in the presence of crowding, and not effective in performing rotational movements, especially of rounded teeth. Extrusion movement is harder to control with only 30% predictability. The aligner seems capable of controlling the movement of the upper molar body when a distalization of 1.5 millimeter is prescribed. And Apadihe, 2022, concluded that the mean efficacy of tooth movement is 50%, tipping is 80%, translation 20%, extrusion posterior 10%, and root movement only 5%.
Do you guys hear him okay in the back?
I
No
want to
need
use
the microphone?
mic. That's okay.
Okay.
So, conclusion, limitations and constraints of tooth movement with aligners. torque control, difficulty in three-dimensional control of proper root inclination. Success rate of maxillary central incisor torque is approximately 50%. And tooth rotation control, rotation success rates generally range from 33 to 71%, averaging around 50%. Particularly challenging for cylindrical teeth such as canines. Insufficient coupling force on cylindrical crowns. Vertical tooth movement. Average success rate for extrusion, pulling teeth out, is about 30%, and particularly low success rate of 18 to 25% for maxillary anterior teeth extrusion can remain challenging when with attachment and overcorrection. Other limitations, difficult anchorage, anchor point management, and potential for unexpected tooth movement. Important consideration for treatment planning for not suitable for skeletal malocclusions. Severe cases requiring significant tooth movement need combination with a conventional appliance. So biological and clinical challenges specific to adult orthodontics. That is a slower tooth movement compared to teenagers. More pronounced alveolar bone reduction, resorption, and greater increase in distance from CEJ to alveolar crest, and reduced bone sensitivity to mechanical stress, and decreased bone remodeling capacity, and periodontal tissue vulnerability, accumulated damage to periodontal tissues over years, reduced supporting bone due to previous periodontitis, risk of gingival recession, careful consideration needed when moving teeth in areas of thin alveolar bone, and anchorage management, unable to utilize skeletal growth for orthodontic purposes, special measures needed to prevent unwanted tooth movement, and frequent need for temporary anchorage device to reinforce anchorage. Think about wide variations in skeletal patterns. Adults have already finished their growth. So if there is a skeletal irregularity, they will choose surgery or camouflage. In class 2 and class 3, surgery is often done because it greatly affects the appearance. However, when it comes to transverse discrepancy, it is often camouflaged. Profit and White claimed that 30% of adult patients had transverse discrepancy. So, Dr. Bernardsdell commented that at the figure D, adult female after non-extraction orthodontic treatment and unsuccessful correction of severe transverse skeletal problem, note recession in premolar areas and orthodontic instability. E, same patient as in D after 4 premolars had been removed and orthodontic treatment in which the transverse skeletal discrepancy is camouflaged. Observe recession on second premolar and first molar. So severe lateral skeletal deficiency in adults is prone to periodontal tissue overload and instability with orthodontic tooth movement only or extraction camouflage. Skeletal expansion with surgical assistance is therefore necessary. In 2002, Lee et al. Treated 20-year-old patient with severe transverse discrepancy and mandibular prognatism. Before orthodontic surgery, the patient used an expansion appliance secured to the palate by means of mini screws, mini screw assisted rapid palate expander. And the authors concluded that it is an effective treatment modality used for transverse correction and which might eliminate the need for pure surgical procedures in patients with craniofacial discrepancies. And this paper's aim of the present study was focused on the improvement of bodily movement and optimization of the surgical osteotomy in adult patients with application of the Dresden distractor. This is a dental implant, the side of the palate, and using a bone fixed expander. So Dresden distractor is suitable minimally invasive tooth independent bone expansion method, protecting teeth and causing skeletal as well as dental effect with tipping reduced by 10 degrees. And 2016, Dr. Moon introduced the MSC appliance, which is very widely used in now. So after expansion, what should we do for complete the treatment? So assume that this is a no transverse discrepancy, but if we have a 10-degree inclined lower molar, maxilla is bodily constricted like this. So after orthopedic correction, the occlusion is like this. So from here to the final wall, we can move like this. This is a tipping movement. This is good for clear align treatment, I think. From here to here. It is very easy, I think. So the first case I want to present here is a 49-year, 10 months female. 49 years, and profile is good. Little bit open bite tendency, and she has a crowding on upper arch, and you can see the lower molar position. Lower molar is inclined, little bit lingually and a little bit majorly. So we want to upright molars, and then lower arch, as a result, expanded, arch developed, and then we need bodily expansion for maxilla. So after using MSC appliance, I cut the leg for scanning.
Did she have any osteotomy at all?
No,
or
no.
Just that.
Just placing the MSC. So looking at the cone beam, base widened 3.2 millimeters, and molar area 7.5 millimeter. It means not only a bodily expansion but also a tipping expansion also.
I'm sorry to interrupt. What size were the implants you used for that? Like the length and diameter? Do you remember?
What?
The length and diameter of the implants you used for that?
I don't remember for this patient, but we make our MSC with cone beam CT data incorporated to STL file, and then we are looking for the enough bone thickness, more than 2.5 millimeter, and then my professional lab designed the proper place and the proper length of the screw. So it depends on the some patient only 11 millimeter, but some need 15 or 17 millimeter.
Thank you.
So you put it in, or surgeon put it in?
No, I put
You put it in.
only by myself. It's easy. It's easy for. This is a limit for other orthodontists. I don't like blood, but we can do by myself. So this is after expansion. You can see how much expansion is achieved.
And you never have one that it doesn't go because you did not cut the side?
Cut the
Cut the osteotomy, no?
No.
Huh.
And for motor, I already said that this is a tipping movement, may be easy, but how about upper right laterals? Is positioned linearly. To confirm the position of the upper right laterals, crown level is pretty lingual side, but root level, it's almost aligned. So it must be predictable. Then I finished this case 1 year, 2 months. Before and after.
How long did you leave the expander in?
Screw.
Yeah, the screw.
After complete expansion, at least 4 months, 4 to 6 months. And this is a before and after. One more case for 21 year, 10 months female. Class 2, constriction, crowding case. This is the case. Upper lateral is completed, broke out. And again, you can see the lower molar position, lingually inclined and majorly inclined. So we want to upright and expand. And profile is good. So I don't want to extract teeth. So this is after MSC expansion is completed. And you can see the class 2 canine relationships. So I start using a carrier motion for molar correction and making some amount of space for upper arch. In this case, we have orthopedically a 7 millimeter expansion, and after carrier motion, molar position is likely tipping back to plus 3 millimeter. You can see still lower molar is linearly positioned. And then this is our first clean check. And after first clean check, the situation is like this, and this is the second clean check.
Excuse me, Doc. I noticed that you've placed attachments on the lingual surface of the lower first molars.
Lower first molar's lingual surface is free space for attachment. There is no occlusal interference, and normally a lingually tipped is a really rigid engagement with aligners. So I love the place of lower lingual surface. Patients don't love that. It is very difficult. So we instruct some amount of time, maybe 20 to 30 minutes instruction, and
2 weeks. I tell them 2 weeks. I put it on there all the time. Huge, big ledge.
especially for extraction case. it is very useful for lower lingual to not to lose the angulation of molars. Third, it is molar area. It is almost finished, but only upper lateral incisors need to control more. So after this situation, it is very easy for using a multi-bracket. Maybe 3 months is enough, and I suggest patient to use maybe 3 to 6 months multi-bracket treatment is better for you, but she don't want to do that. She said that aligner is already part of my body, so I don't care how long treatment is needed. So this is third, but when we observed at the position of upper right laterals, both root position and crown position is lingually positioned. So this is very difficult using clear aligner treatment. So this is fourth. Fifth, now we have a cone-beam CT. Sixth, seventh,
You keep those shelf biplate things. It doesn't grab the tooth as tight. You
maybe
keep them.
maybe.
I hate them because then you lose the grab on the linguals.
Yeah. But I'm afraid at that time that posterior open bite.
Open bites, okay.
Eighth, ninth.
I'm with you.
Then Invisalign count 5-year limit is coming, and patient already satisfied, but I don't satisfy the right supposition, so I'm keeping, but time limit is coming. And this is the final goal. This is final. Before and after, she had a good incisor showing. And this is before, after. Before and after. Looking at the position of the lateral incisors in the crown level and root level. This is before, and rotated 48 degrees. This is also difficult to control with clear aligners, and the position lingually. And after, almost good, but root position is still a little bit lingual. And you can see that there is no bone for lateral side of lateral incisors. So maybe this is a limit. And then I want to talk about the possibility of progressive alveolar bone resorption with aging. This is the third case. So adult patients over 40 years represent a challenge for an orthodontic or periodontal treatment approach with high incidence of pathologic tooth migration, orthodontic treatment need, and periodontal breakdown. And the age-related abatements in mechanosensing and mechanotransduction in adult cells and periodontal tissue may contribute to retarded and balanced bone metabolism, thus hindering alveolar bone reconstruction during orthodontic treatment. And this is from a plastic reconstructive surgery paper for young female compared to all female skeletal patterns. And skeletal aging occurs and bone resorption and alveolar bone insufficiency for orthodontic treatment. So in nowadays, especially in Japan, is mean age is older and older, and we have a very small number of orthodontic treatment received in teenagers, maybe 20 or 30% of teenagers. It's growing, but still low. And then they growing up and they have 40 years and 50 years. And during COVID era, Invisalign company marketing so successful to under a mask you can treat by clear aligners, and then so many adult patients is coming and they have so many problems with periodontal tissues. And then this type of treatment is focusing for adult treatment, periodontal osteogenesis. They recover the periodontal alveolar bone regenerations. Then look at the third case, class 2 severe crowding with periodontal complications, 47-year, 1 month female. This is occlusion. And she has not active periodontal problem, but she has not only a horizontal but also vertical bone problem and so severe gingival recessions. And
What is that? Pins?
for
Ooh.
that is for
I like.
endodontic
Mm.
treatment. Because of the in Japan we have a national insurance system is covered for periodontal endodontic treatment.
Mm.
It's normally one endodontic treatment can be treated by $10 for each root.
Nice.
Nice, but terrible.
Nice.
So we have so many situations like this.
Interesting looking. The lower ones are. Mm.
Yeah. So she is
Wow.
a very good patient. She followed general dentist, long time, and she don't care about her crowding. But now she has so many mobile teeth and coming to my clinic. So, how can you treat this patient? We have to think so many considerations. We have to consider occlusal interference during tooth movement and minimize tooth movement. Evaluate the amount of type of root movement individually. And we need collaboration with the periodontist and program the timing of tooth movement. So occlusal interference during tooth movement is I experienced one case like this, 65-year female. She is referred from my general practitioners, and molar she will replace implant, and she GP asked me only lower treatment to solve crowding after implant placement. So I thought that this is a very easy mechanics, so okay, I can do that. But after starting, this is very complicated because the second premolar area, we have a strong interference, occlusal interference during the leveling and alignment of the lower dentition, and then she had the mobile upper first premolars, and GP find that it's mobile too much and fixed by GP, and I was sweat and intruded by occlusal interference. And finally, I finished this case, but during the treatment, it's very, I think it's very dangerous for preserving the upper premolars. And minimize tooth movement. Evaluate the amount and type of root movement individually. So this is my experience controlling individual tooth movement, learning from this patient. This patient is coming only for concerning about crowding. Looking at the upper right second premolar is impacted, and at the orthodontic diagnosis, she found that she never thought that she had a premolar. And I talk about extraction, but she never accepted that she don't want to have a surgery. So I decided to leave them at the same position, and she had lower incisor problem. So extract the lower incisors, and looking at the cone beam CT data, we have impacted second premolar like this. So we can't move number 16. We need to intrude 14, buccal cusp 1 millimeter, and move 14 buccally center with the root apex, and we cannot rotate 14. So this kind of movement, can you do this with a multi-bracket? It's very, very difficult. For me, it's possible. But using ClinCheck program, I programmed like this. And this is a ClinCheck. I use a lot of IPR for this patient. Extraction of lower incisors, one lower incisors. I didn't touch the molar, and my prosthodontist will cover it after this alternate treatment. And this is the result. This is the result. So this type of goal setting and tooth movement cannot be treated by bracket and wire system. And collaboration with the periodontist. So program the timing of tooth movement. I made for this patient for several goal setting. First, I thought extraction of a lower incisor, one lower incisor, and upper laterals.
Lateral.
Not canine, laterals. Because this premolar is major tipping, and after extraction of canine, we need to root must be moved majorly. That is no bone. So I decided to, I tried to this type of movement, But when we see the root position, this is the root movement and upper and lower, we check the upper and lower. Both upper and lower root position move to Bakari B, 2.1b, 0.5b, 1.10b, 2.1b, and both upper and lower also. So this is not acceptable for this patient. So I changed the goal position for extraction of both upper and lower premolars. But if we extract both upper and lower first premolars, still the root position move to Bakari a little bit. So I adjust the goal position again. Like this. I incorporate the upper molar distalization. So no lower molar majorization. Then I could position the both upper and lower incisor root position a little bit lingering.
How many aligners are 86?
Maybe finally 70 or 80. And in this case, if the patient come to periodontist is difficult to to make a clean environment, and the situation may not caused by malocclusion, but are strongly accelerated when problems occur. And maybe only periodontists are waiting for extraction teeth in sequence in areas that are difficult to clean. Orthodontist only, we want to improve occlusion and aesthetics, but thin phenotype, available insufficiency, and risk of periodontal acceleration distraction during orthodontic treatment, and require delicate mechanics and avoiding occlusal interference. So I asked periodontists to transform the phenotype by periodontal regenerative therapy and clear aligner as an orthodontic tool with designing tooth movement that precisely control tooth movement. And finally, periodontists do both PAOO and CTG simultaneously, but donor site is limited, so he wants to do lower first. And I extracted lower premolar first and keep upper premolar as an anchorage for upper molar distalization. Now after upper molar distalization is finished, I asked periodontists to do upper PAOO and CTG, and then start movement for upper arch. And it takes 2 years. This is the result.
Very nice. Beautiful.
And before and after. This is 4-year retention. During the 4 years retention, she lose her lower right second molar and replace the implant, but still good occlusion. So this is interdisciplinary treatment. Throughout this treatment experience, I think that quality of bone is very, very important for life-changing staging. And if we have a normal occlusion, the bone quality is getting good and good during the mixed dentition and permanent dentition. And plus aging is reducing the some amount of quality of the bone. But in this normal occlusion, patient have a perio and periodontist recover the bone quality. This is a periodontist work. What is the orthodontist work? If we have a malocclusion, some amount of alveolar bone quality is less than a normal occlusion. So we expand by orthopedically, and orthodontic treatment is making a newborn to recover the normal range of the bone quality. This is the orthodontist work, normal work. But if we have a malocclusion and perio problem, only periodontist cannot do. Only orthodontist cannot do also. So those photos are from my periodontist, and right side is this is a clear aligner treatment. No consideration of the bone housing, and it's almost out of the bone. Almost.
Still has a little bit in there.
A little bit, yes. And actually, this case is recovered by after periodontist and orthodontist combination.
When they did the bone graft, did they do the lingual and buccal or just the buccal? On the labial only, or in
It depends on the case.
that case?
In that case,
just
labial
only.
labial only, and he used that's from GC. It's only available in Japan. Bone regeneration.
I know, I'm going there. I'll make an appointment.
Peter, on that case, did you, with the tooth outside of the
Yeah.
bone, did you move the tooth into the bone and perio? Or
Yes.
are you saying that perio alone?
First perio, and then using a bracket and
Moved it back?
move the back.
Question, please.
Peter,
Hi.
The previous case, wonderful. After you finished it, did you have the periodontist do the bone graft? I mean, that the bone graft. Do you have any or gingival graft after that?
After no,
Just only the.
just before,
So
just
you-
before.
you found like a lot of intrusion in that case from the aligners. I mean, it seems that the recession seems better in the case.
Mhm.
So do you see, I mean, with this CBCT, do you see that you have improved the overall intrusion?
Not by intrusion, but PAOO is bone regeneration during along with the orthodontic tooth movement. So it is different.
There's also a connective tissue graft that can
Yeah.
actually do the epithelial attachment with no bone. So they did both the bone graft and connective tissue graft. The American thing that they show in the journal do not do connective tissue graft at the same time. So that time you can cover the root. It's normally a two separate thing. And this, if they did it in combination, I'm flying to Japan.
Because if you just do like the
I need it.
graph,
You need it?
it's gonna disappear, it's gonna, right away. Yeah, I think that's the key, was that not only did the Wilco, the bone, but then also the
Connective tissue graft, that's how you got the recession to go away. But it's not bone, it's connective tissue.
And there was a CBCT in the end. You kind of skipped past it, but did the bone graft, could you see the bone graft in your final CBCT?
They wanna see the bone graft in the final CBCT on that case,
4 years,
yeah.
4 years, like this.
Is the bone graft still there?
You can't see it in the CBCT.
Yeah, I can see.
It's always looked like that, even if it's there. A lot of times you have
Only
if it's really thin, it doesn't
root
show.
apex area, only root apex area, you have a bone graft. Anyway,
Yeah.
skip.
Excuse me?
Here,
Did the periodontist recommend a fixed wire retainer on the bottom for like as a splint for periodontal therapy?
What do you say?
They want the fixed retainer or not, how mobile are the teeth?
After orthodontic treatment is mobile is normal, and she still use a liner as a retainer. No fix. So orthodontist and periodontist collaborative work is only can do this type of treatment. And I think both of this process is accelerate process. If we leave no treatment, it will acceleration with bad status. And if we want to treat for this blue arrow, we need to accelerate treatment, quick treatment. So we need to more precise goal setting and target and move pretty fast.
So
Pretty
did
fast.
you change
She
the
changed the
aligner?
aligners 4 days and 4 or 5 days.
That's what, yeah.
Yeah. That is why normally after PAO, we change the wires every week or
Mhm.
every 2 weeks. It mobiles a lot. But after that, it stable.
So normally after you do that procedure, it heals after 8 weeks. Did you go back to every 7 days? So did you do every 4 days changing?
Yeah.
And then when did you switch to 1 week? Or you keep on going every 4 days,
Every 4 days.
the whole time?
Every 4 days for
How
3
many?
months. After 3 months. 3 months.
Okay, not 2. Okay, cool.
So I want to summarize clear aligner and adult treatment. With a feature of adult cases, a greater skeletal variation and frequent thin phenotype with alveolar bone loss with aging, requires more precise treatment goals and tooth movement planning. And characteristics of clear aligners are effective in tipping movement, and root control depends on attachment design and aligner engagement, and allows individualized planning, what moves, when, and how. And using clear aligners in adult cases, skeletal corrections simplify movement planning for aligner optimized mechanics and helps pre-plan efficient goals in cases with alveolar bone deficiency. When combined with periodontal regeneration, aligners enable precise, biologically tailored movement and unique digital advantage. Thank you for your attention.
I am not gonna do a discussion, I would like you to just ask the question instead.
So how do you, well, for the aligner, like, how do you feel that, with the insertion and, like how you prevent the further intraoral insertion? And that's the first question. And the second question is that how do you communicate with the patient that, this is like the good scenario, like everything's great, but, like the worst scenario that you might even, worsen the periodontal, condition. So how do you communicate with the patients and
For periodontal concerning that periodontist can communicate with a patient.
I
And
mean, I've
Terrible
also
situation to
seen a
start
lot of multidisciplinary cases, and there's many cases that periodontists refer me, and with this hopeless condition, and they hope that ortho can solve, can help.
You
But
need to talk to them.
yeah, it's like how do you make decision that this is the case that you should make a decision to go ahead, or the case that it's just very difficult because we cannot really give a promise that they're gonna get a good result in all.
well,
Never promise.
never promise.
Never promise to begin
But
with.
promised is if she did nothing, she will lose
For
her
sure.
teeth
Lose your teeth, yeah.
sequentially. So that is a promise.
It's not your
We,
problem.
we, we discussed the possibility and for the future.
So Hiro, do you just enjoy these challenges? Or do you ever use like, some sectional brackets or maybe some lingual brackets, just to help
Yeah, just a
guide
few
the
months.
teeth? Or you just wanna, like I said, challenge yourself with the aligner?
Well, for aligner treatment, I have more than 10 years experience, and almost all cases I treated aligners, and I made so many mistakes and so many, I feel, limitations. And in this case is if she has no periodontal problem, this is a very easy case, I think, because the root position is good, and treatment is done by tipping movement, even in so much crowding. So in this case, I think it's successful
Like for example, that one case where the 9 refinements were for the lateral incisor.
Yeah.
Why not just put like 3 or 4 lingual brackets to help rotate the lateral?
Patient don't want to place a bracket,
Even lingual brackets?
even a lingual bracket. She don't want to do.
In that exact scenario, I was wondering, why didn't you just do a local PAOO?
Local.
Just do that section where you were struggling to move that one tooth.
Ah,
Could you do it just
yeah.
in that area?
That is another option, I think, and there is no bone. We had a totally lingual position, so I didn't explain that the PAOO for that patient because
Maybe
it's
you could try with 5 refinements instead.
because it's invasive treatment, so maybe that's good for that patient.
Huh?
So what do you do if you do mostly aligner cases? What do you do when the root isn't in a good spot?
He changed his plan to match the roots.
You just change your plan,
To
or
match the
or
roots.
is that the 20% that you do
Yeah.
braces?
That is 20%. That is scientific data. That is not described how the clean check design and how the patient compliance, patient engagement. That 3 point we have to think about precise tooth control. Good clean check design. That includes the goal position and the staging and attachment design.
Yep.
And the second is patient cooperation with time. And third is patient skill for engaging the attachment and
Yeah,
aligners.
choose versus-
Yeah, so all of that 3 condition is perfect. Then we have a good result. So we try first.
look good. There's some muffins still left, and fruit, and coffee in the other room, and we'll be back here.